Okay, the topic of our event today is community and academic centers working together for best patient outcomes. This topic is one that I am really excited to have a discussion on today and has been in the works for several months. I've heard from many patients in our communities over the last year that they receive care in their community centers and are interested in how they could work with an academic center, or that they want to get a referral to an academic center, that they're currently being seen by both and they're curious how that works. We know that having working relationships between academic and community centers gives patients the best opportunity to receive the best care possible, and it helps to break down some healthcare barriers. So today, our panelists are going to discuss this topic. I'm going to take a moment to introduce our two panelists. First, we have Dr. David Swoboda. He is the Director of Leukemia at Tampa General Hospital Cancer Institute and an assistant professor at the University of South Florida College of Medicine. Prior to joining TGH, Dr. Swoboda served as the Chief Hematology Oncology Fellow at Moffitt Cancer Center and Chief Resident at Georgetown University Hospital. He's actively involved in the care of patients with acute leukemias and myelodysplastic syndromes, in addition to serving as principal investigator on multiple clinical trials in these diseases. Dr. Swoboda has been an active part of our MDS education since the very beginning, participating in our very first webinar and also our HealthTree University program and providing research updates during medical conferences. So I'm really excited to have him here today. During our last trip out to Tampa General, he and I had a conversation about today's webinar topic, and I knew he'd be a great one to have present here. Dr. Swoboda then introduced me to our next panelist for today, Dr. Tony Kurian. Dr. Kurian is a hematologist-oncologist at Florida Cancer Specialists. He completed internal medicine training at Loyola University Medical Center in Chicago, where he served as chief resident, and went on to train in hematology and oncology at Moffitt Cancer Center, where he served as chief fellow and completed additional training in blood and marrow transplant and cellular immunotherapy. He currently works as a community hematologist and medical oncologist, treating a broad range of conditions to meet the needs of the local community that he serves. I am so excited to have these two incredible physicians here with us today to help us address this topic. Normally, this is where we turn the presentation over to our speakers, but today is going to be a little different. This webinar is going to be more discussion-based, so we're going to work through some questions and let our two panelists really discuss this topic and share their thoughts before we get to all of your questions at the end during the Q&A. So now we're just going to get into the discussion. The overall goal and the main question we're trying to answer is, how does collaboration between community and academic centers help patients receive the best care possible? That's a really big question. So we're going to start with a little bit of context on each of you and your experiences with patient care. So Dr. Kurian, can you give us a little bit of an overview of your role in community centers and patient care, and maybe some challenges you experience?
Yes, absolutely. Thank you for the kind introduction, and thank you for the opportunity to participate in this important discussion. Again, I'm Dr. Tony Kurian, as was stated, I work in a large group practice, Florida Cancer Specialists, and I serve the patients in Venice and Inglewood, Florida. So these are smaller communities south of Sarasota. I'm originally from Chicago. I grew up in Tampa. I attended med school in Tampa. Went to residence in Chicago and came back to Tampa and trained at Moffitt with Dr. Swoboda. So we know each other well as well. I just broadly, I think that the role of community clinics in the care of AML, MDS, and really all blood cancers, leukemias, and lymphomas in general. I think it's a really critical role in serving the community for folks like myself and community practice to partner with academic centers for optimal care delivery. I think we play an important role really in the full spectrum of the disease journey, in that oftentimes patients come through, my clinic with abnormal blood counts or symptoms. And so I think oftentimes a community oncologist such as myself play an important role in identifying and making a diagnosis, whether that's through imaging, bone marrow biopsies, additional advanced testing like NGS, and then through to management of low-grade blood cancers that might just require monitoring and surveillance, to supportive transfusions and monitoring, to delivery of treatments, and then of course identification and referral. Oh, I'm so sorry. There's a storm warning in Florida. So that's my phone going off. I apologize for that alert there. But yes, importantly, identification and referral of the appropriate patients to academic centers for, induction treatments or specialized treatments or transplantation or additional consultation by specialists, leukemia specialists such as Dr. Swoboda or lymphoma specialists. And then, just day-to-day management of, acute symptoms that might occur, infections, infection prevention, treatment-related side effects. And then, all the way through to post, definitive treatment care or post-transplant monitoring, long-term survivorship. So I think we in the community play a pretty key role across the spectrum, broadly for these diseases, and it's patient to patient. And I think that sort of revolves around, certainly access as one important facet, right? Availability of like leukemia doctors, such as Dr. Swoboda and others, is limited. So, well, not limited, I should say. But I think when these subspecialists are able to partner with folks like myself in the community, it allows folks like Dr. Swoboda to see more patients and make sure they're all getting the care that they need and their needs are met. Some may have issues with insurance coverage, depending on what the requirements are for the local academic centers. But also just purely like distance. We're a few hours away from Tampa, which would be our closest academic center. And that's not easy for most people. And oftentimes with these blood cancers, the care needs may be very high. They may need very frequent visits. And so it's a little easier to accommodate that when you can go somewhere around the corner. And certainly if you're traveling frequently, very far distances, there's certainly a lot of costs that might accrue with frequent visits, out of town. So yes, I think there's an important role for collaboration. And as far as some challenges with care delivery, we're in these smaller clinics, such as the ones I work in. Certain things require a little extra time and coordination. So even just doing a blood transfusion, I have to coordinate with the local hospital. It might take a day or two sometimes. And so I have to kind of make some practical decisions about when to make transfusions and things like that. And sometimes we'll have to send folks to the ER depending on the situation. So resources in that sense. And then another, important challenge sometimes can certainly be communication and coordination with our academic partners. So it's great when we have good working relationships, such as myself and Dr. Swoboda and others. But when we don't necessarily know the other colleague as well, and it's not necessarily always simple to coordinate between institutions. But that's also highlights the importance of making sure we're networking well and having a good lines of communication and ability to collaborate. So those are some broad thoughts on the topic.
Thank you for providing that context and kind of highlighting what, your role is in patient care. Dr. Swoboda, same questions to you, your role in an academic center and patient care and some challenges that you experience.
Of course, yeah. Thank you so much, Mary, for the invitation to speak at this event. Yeah, I'm going to echo a lot of the same points that Dr. Kurian made from, my side. I'm an academic physician. I focus on a small subset of diseases, mostly MDS, AML, and myeloproliferative neoplasms. And I run the leukemia program, which has a large inpatient service in addition to the, care that we can provide in the outpatient setting. And what I would say is that, we can't provide the best care possible without our community partners. It's the reality, because I take care of patients from across in the entire state of Florida, and sometimes even beyond that. And without local care, the challenges and logistically for patients would just be way too much. And so I think all patients should have both the community and an academic provider and their care, with the academic provider primarily serving for, to be that specialist, on very rare or very challenging cases that, just aren't, seen at a high enough volume in a community setting. And so again, I focus on a couple diseases. That's all I see in my clinic all day, every day. And so I do research, I do clinical trials. And so you become very comfortable and very specialized and really being able to understand the subtleties of each individual patient, each individual situation within the disease. And, with how much cancer care is changing, especially with the way we think about how molecular mutations or somatic mutations affect cancer, it really does become very complex in not only the diagnostic side of things, but prognosis and treatment recommendations. And so to be able to understand and provide that insight, but then work with the community provider to deliver the actual care at home for anything that's standard of care, it really is what's best practice for our patients that we take care of. But it's not always sort of it's not always a one size fits all for patients. Some of my patients might spend, 10 or less % of their time, with me, and the majority of the time with the community provider. I might see them once every 3 months or every 6 months. And that's right for them, and that's right for the setting that they're in. Some patients spend 80 to 90% of the time in our clinic, and then we'll get, certain things within the community clinic. And so it really is just an ongoing discussion, an ongoing collaboration, and very specific to an individual's patient's case. When we talk about challenges, like Dr. Kurian said, in academics, we do, want to see as many patients as we can possible and touch as many cases as possible across the state of Florida or beyond. And so ultimately, in order to do that, we are, somewhat space limited in what we can actually do regarding chemotherapy, transfusions in our main site. And so having all these collaborators is the way that we're able to, provide best care to patients at a higher rate and a higher volume. And so, other challenges within an academic practice, sometimes community practices can be more, actually more efficient. So they can get, have larger infusion centers, deliver, chemotherapy quicker for patients, and, get, certain testing quicker because they don't have to deal with, a larger volume or, certain things that we have to deal with at a larger academic center. So I would say, that's some of the benefits and the challenges. I think to echo Dr. Kurian, communication is really key in making sure the relationship is the most successful for our patients.
Thank you also for providing that context and kind of sharing a little bit about the academic side. I want to kind of get into the decision making that goes into patient care. So patients are making a lot of decisions about their care, especially early on. What kinds of factors, both medical and situational, play a role in informing where a patient should receive care and who they should have on their medical team?
Yeah, I can start by taking this. So, I think it really depends on a little bit of the rarity of the disease, because, that provides, less or more comfort level in their community provider. Clinical trials, I think if it's a disease type that really needs access to a clinical trial, there is, Dr. Kurian's practice is very large. They do have access to a lot of clinical trials, but they tend to have access to clinical trials for things that are less inpatient focused, and more community driven. And so, we, at larger academic centers that tend to have, more, rare clinical trials, more inpatient focused clinical trials for patients, that have acute leukemias that spend a lot of time in the hospital. And so that's sort of the difference in the different settings there. But I'll turn it over to Dr. Kurian to comment as well.
Yes, I would echo basically all of those sentiments as well. I think that I think this really becomes a very individualized decision, specific to the patient, their particular circumstance medically, and then more broadly, their life circumstances as well. So there's a lot of factors that play a role. When we're talking about blood cancer, I mean, oftentimes for most diagnoses, I do bring up, seeing a specialist, getting a second opinion. I think it's fair to say that really any cancer diagnosis is serious, and it's really important that the patients feel comfortable with the plan of care, and they feel confident that and comfortable with the care that they're getting. There are certain situations where the treatment plan may be, you know, fairly, I guess, straightforward as far as what should be done, and we may have very readily have access to what treatment might be necessary and diagnostic testing might be necessary. But there are all sorts of circumstances where, we're either dealing with something that is a rare diagnosis, or we're dealing with something that might be a common diagnosis, but there's a really nuanced situation that's occurring. And so, you know, uh, there are circumstances where medically I feel very strongly that my patient would benefit from seeing someone at an academic center, depending on the diagnosis and depending on the circumstance. And in those situations, that's what I explain to the patient. And then there are other situations where, I may not feel as strongly that that might be needed. That's not going to be the case in some of the diagnoses we're talking about here. But regardless, even if that's the case, the patient may just feel more comfortable having had a second opinion and feeling like, hey, we got two sets of eyes looking at the situation, and we're all in agreement about what the plan is moving forward. And in that situation, that's the right thing to do for that patient. But there are numerous, factors that play a role for any particular patient. So I think considering, how that patient and their family is feeling about the diagnosis and the treatment plan, and then also partnering with the doctor you're working with to figure out if it may be of value to kind of get an additional opinion from someone at an academic center or a second opinion. So it's sort of specific to the situation, I would say.
Yeah, and I agree, and I'll comment on that a little bit more. Because within heme malignancies, which is sort of the focus of this community event, there is a lot of new therapies. So we have bispecific T-cell engagers, which is one type of new therapy. We have CAR T cells, which is genetically engineered T cells, another type of therapy that at this time really, for the most part, aren't able to be delivered in the community setting, although that's changing as these newer therapies become more readily available and more providers are becoming more comfortable with them. But currently, to get access to some of these, new therapies that are not, any longer, on clinical trial, you will have to partner with an academic institution. But in the long term, and something that we're working with, with a lot of different practices, including Florida cancer specialists, is how best to partner on these things as well. So, is there an opportunity to do certain things, transplant being one of them as well, at this main academic site, and then pretty quickly transition them back to the community to get the rest of their care, because most patients want to spend the least amount of time, obviously away from their families, away from their homes. And that's even, as an academic provider, that's my goal, is anything that we can do closer to home, we definitely try to do, and anything that I can do to make patients' life and their quality of life better, whether it's through, telehealth visits, more labs, and, locally, anything that we can possibly do, we try to do in our clinic.
I'd love to hear some examples. You mentioned that you guys work together, your centers work together. I'd love to hear some examples of how either of you have partnered with people at, if you're Dr. Swoboda at the community or Dr. Kurian at the academic level. I'd love to hear some examples.
Yeah, so I'll give you an example. So just like how the life cycle of a patient could potentially be. So, let's say a patient shows up in Dr. Kurian's clinic with low blood counts. He would evaluate the patient, potentially do a bone marrow biopsy, and let's say that bone marrow biopsy comes back that the patient has acute leukemia. He would then send a referral, potentially call me and say, we'd like to refer this patient up. What do you think? And we would quickly evaluate this patient in my clinic. And ultimately, most of the time, we would bring them into the hospital to deliver chemotherapy inpatient for most types of acute leukemias. They would spend anywhere between 2 weeks to 4 weeks in the hospital, being managed by our team of specialists that focuses on blood cancers and really focuses on inpatient blood cancers, and a group of nurse practitioners and PAs and pharmacists that are really all focused on just that. We would get the patient through that therapy. They would be safe to leave the hospital. And then, we have what's called a transitional care coordinator that would then reach out to Dr. Kurian and Dr. Kurian's office and make sure that we have the patient scheduled for a lab visit, follow-up visit in the office locally. They would be discharged. They would follow up, get their labs and things that they would need there. I would stay involved in that patient's case, whether it's through telehealth visits or in-person visits, depending on what's needed. And then, if we need to bring the patient back to Tampa for certain therapies, we can definitely do that. Or if we're able to manage things locally, we would do that with just, kind of the expert insight. And that's how it would sort of go. And so this is something that we do, every other week, we're, having similar situations, across, doctors, we're doing this every day, multiple times a day, where, we're getting these types of referrals, managing things, and getting them back to, their local provider. So that's sort of the life cycle of an acute leukemia patient. Dr. Kurian can talk about his experiences from his end.
Yes, I'll share a couple examples of some patients we have in common, and I think there's this can look very different from patient to patient. So on the higher acuity end, I have a patient that is admitted at our local hospital with some concerning symptoms, and I did identify that patient has an acute promyelocytic leukemia, a very aggressive cancer that can progress very rapidly, but has highly curable. And I think that this patient, it's very important that we act very quickly, and that this patient is in this particular patient's case, I want this patient up to see Dr. Swoboda managed in his hospital, so that all the care just as he outlined is going to be delivered. So I call Dr. Swoboda, we transfer the patient up there, and we kind of go through that process, and when the patient is ready to get back home and have spaced out visits, we kind of pass the baton off back to the local care for the more frequent visits. I can follow that patient weekly for lab monitoring, and I could see him or her very frequently to check in, and then much of the longer term consolidation type of treatment can be delivered close to home, and then meeting with Dr. Swoboda intermittently along the way, and as issues come up, I may reach out to him to kind of triage situations as they may occur. And so that's one example. And on the other end of the spectrum, I may have someone with a lower or more indolent type of myelodysplastic syndrome. But one patient in particular had some complex comorbidities, and I really thought it would be strong. I mean, most of these patients I am discussing having them plugged in with academic centers, but this one in particular, I felt very strongly that he should, and so I had him go up to see Dr. Swoboda. We came up with a treatment plan together, and oftentimes he's at my office locally to get most of his treatments and care, but checking in again with Dr. Swoboda every few months or so. And so those are just kind of two examples of different different journeys that patients may be experiencing, but scenarios where collaborating really, I think, allows us to give a higher level of care for that patient and meet their needs.
Yeah. And something that, we really harp on, in our group, because I think it does make a huge difference on both sides, is just the communication piece, as we spoke about earlier. And so, every time we see a patient in our clinic, we make it a point to, either call or send an email, really outlining what's been discussed, good or bad, what our recommendations are, trying to be as specific as possible. And do this as, really as quickly as possible. So let's say, I'll see a patient on a Monday sometimes, and, they might be starting therapy on a Tuesday in Dr. Kurian's office. And so, I'll communicate the information so that when he walks in with this patient, he's not saying, oh, I don't know what was communicated. I need to call Dr. Swoboda. I need to figure out this and that. He knows exactly what the plan is. We've already communicated, gone back and forth, and made sure that we're both on the same page. We both agree. So then when he walks in, he is, talking about the plan that I already discussed, and we're moving right along to next steps. So that's really the best way to do it. The nice thing is, we do, the farther and farther we get along, the more, integrated our electronic medical records start to become. And so I actually have access to Dr. Kurian's electronic medical record. We try to do a good job, but I think that's why we have to communicate with getting the records back to his end as quickly as possible, so that they have the labs that we have done. So we're not repeating testing. We're doing a lot of redundant testing. We're able to see and say, oh, you got labs yesterday. I don't really need to repeat that again today if there's no value add. I think that's the difference between having, a good academic community partnership with good communication, in a situation where you don't have that same bidirectional communication. And you, as a patient, you can normally see it pretty quickly when you go in and one end just, feels like it's disconnected from the other end. You start to feel like, are my doctors really talking to each other? And I think for best patient care, if that's not the situation, then, I think, you should be looking for a situation where you do feel like, both doctors are on the same team, are, paddling in the same direction for your care.
You mentioned earlier the use of telehealth visits, things like that. There's a lot of barriers to healthcare that a lot of patients experience, and it sounds like this collaboration can help to break some of those barriers. Access, Dr. Kurian mentioned, was a big one. Are there any other areas that you can see this collaboration kind of helping, or examples you have of this collaboration kind of helping to break those healthcare barriers?
Yeah, yeah. I think access is a big deal. I think there's the patients that live in certain areas where there just isn't large academic practices that you have access to. So it's much easier if you live in the Tampa area to go to multiple academic centers. And so what we see is that in the community practices in Tampa, they do send a lot of patients, almost all their patients, to academic centers. The farther you get away, the harder that is. And one way we try to bridge that access issue is, whether it's the first visit or subsequent visits, if we can, and it makes sense in the patient's case, we don't need additional testing. We feel like we have what we need. We will try to offer telehealth. We'll try to offer whatever we can to really just get a touch point in with a patient. And I think a lot of patients, once they get that communication with an academic provider, they start seeing the value there, and then they are more likely to want to travel. But despite that, it's still rural care in the state of Florida, in the U.S. in general, is tough. There's practices that don't, or areas that it's 45 minutes or an hour just to get to the closest community practice that can do, labs for you, and it can be really challenging, especially with, blood transfusions that we deal with a lot in malignant hematology. Getting access to blood easily, readily available, especially if you're needing it multiple times a week, it can be really, logistically challenging. And so, those are things that we've looked into. We've talked to, mobile transfusion units, mobile clinical trial units. I think the telehealth initiatives are really ramping up. We do have what's called TGH at home, where we are delivering some inpatient care, outpatient in the patient's home to try to get better access, outside of the hospital to some of the things that we would otherwise do in the hospital. So, we're trying to do as much as we can, but again, it comes back to having great partnerships, so that it's not just on one side; it's on both sides.
Yes, I agree. I agree. I think that distance is the most obvious one for the areas that I serve, to distance to the academic center. And I think that with that distance, there's certainly can be great costs with all the traveling. Transportation can be an issue. So I've had certain patients who just didn't have the resources to be frequently making trips. And I think in those situations we can help quite a bit as well. And then insurance can sometimes be an issue as well. I mean, so I found myself in situations where I knew a patient might need to be at an academic center for their particular issue, and their insurance, they're having some trouble getting insurance approval at an academic center. We have a financial navigator that might assist. We have certain counties I work in have their assistance programs, and or I might ask different centers. So Dr. Swoboda's group in particular has been very flexible with what being able to accommodate most patients, and so that hasn't been as big of an issue if I have a patient with MDS AML that needs to see him, and then other issues would just be, I think, sometimes folks need to be seen very frequently, a couple times a week sometimes, for blood checks, and so that can be very challenging when you have to travel quite a bit to get that care. So there's a lot of circumstances, I think, where the collaboration can be of a lot of value from an access standpoint.
Thank you so much for sharing those thoughts. And I think that's, a big area of need. And I think this is a great way to help address that area of need. I wanted to go ahead and start looking into some of the questions we've gotten. I think some of them are really relevant to what we're talking about. One of the questions says, how can the community centers communicate with the community PMDs? I feel like PMDs need to understand this person has multiple myeloma, so multiple myeloma better, or whatever disease someone has.
What PMD? What does PMD stand
I am guessing that's their primary medical.
Gotcha.
Their
Like
doctor.
the primary care physician.
Yeah, yeah.
Oh, I see. Okay. At least I guess that can be variable. I'll say at least for in our system, primary cares are linked to all of our notes as well as the academic partners. So, and then there's many primary care doctors that will, if they're concerned about something they're seeing, pick up a phone and just give me a call if they are seeing something concerning and needs to be seen right away. I'm not sure, I guess, if the best question.
Yeah, I can comment as well. Yeah, like what we try to do is, for even from an academic setting, with primary docs, because the reality is that a lot of insurances require your primary care doctor to send referrals for a lot of things, the testing that's done. And so, like Dr. Kurian said, our the way that our build out is, we actually are able to add the primary care doc to the care team. And so we tend to send, all our notes after we sign them to the primary care doctor. each time, so they can have an understanding of what's going on with their oncology care. And then, I know Dr. Kurian is good at this. I try to do this as well. Going out and meeting the primary docs, providing my cell phone to, primary care providers, so that if people are looking to discuss things, they can pretty easily find us. And, you can tell a good office, like if a primary care doctor calls in to our office and asks to speak to me, myself, my PA, we'll give them a call back, within by the end of that day, to make sure that they completely understand what's going on with the patient's care. It's tough though, oncology care is tough when you're, an oncologist. It's very, challenging, ever changing. And so we try to, ensure that our community docs and primary care doctors, completely are on the same page. But sometimes, especially with primary care providers, some of the things that we're delivering, some of the therapies, it is very foreign. And so it does take conversations, and it does take patients to be kind of an advocate sometimes for themselves, and understanding what therapies they're receiving, and how to communicate that with the primary care doctor. But I think ultimately, on both sides, we try to reach out and communicate as much as we possibly can to make sure that things go as smoothly as possible.
And I think we as the oncologists also need to be mindful of what we're expecting and asking of our primary care physician colleagues. So, for instance, a patient with multiple myeloma or MDS that might be transfusion dependent, if folks are needing like weekly CBCs and very close monitoring in case they need transfusion support or have severe neutropenia, or if they're dealing with infection issues as a result of their blood cancer, hey, I really don't think that's a very fair thing for me to put on a primary care doctor to do, because they've got a lot of hats that they have to wear already. So when you have a patient with a blood cancer that has very high needs, I really think that's my responsibility to take care of those issues, and address those issues. So I think also setting those expectations appropriately and making sure we're doing our part. And I think that's a perfect example of something that, I as a community oncologist can fill that role in I would say in a much I would say in a more ideal way than having to rely on a primary care to try to keep up. Just like Dr. Swoboda was saying, oncology care is extremely complex and challenging for even oncologists to keep up with, let alone asking our primary care docs to try to keep up with those needs for those complex situations. So I think I think that's a really important role that a community oncologist can fill, depending on the scenario that the patient is in.
Yeah, and just to touch on, because I see Terry put one more comment there. I think ultimately, we try to have as many educational events as we possibly can, where we do bring, our speakers in, whether it's through dinners, conferences. And so that's really a good way for primary care doctors to access some of the education. But it relies a lot on the primary care doctor to really attend these things, to stay up to date. And, they're not just dealing with oncology, multiple myeloma, acute leukemias. They're dealing with, all the changes in cardiovascular disease, all the changes in pulmonary disease. And so, we have to, set appropriate expectations on what is things that should be in their wheelhouse and should be feel very comfortable managing, and what things that, even though it might be high blood pressure, but if it's related to one of the drugs that we're giving as an oncologist, maybe that's something that we should be managing to the best of our ability, or closely working with the primary care to do that.
I see Vicky asked a question that kind of leads into another topic I was wanting to discuss. She says, many smaller community settings do not offer some of the new drugs like bispecifics that require risk evaluation and mitigation programs, but many patients are unable, whether physically or financially, to travel to an academic center for this potentially life-saving treatment. Can you offer some insights into coping with this disparity? This is this equity and healthcare barrier question again.
I think I agree. This is a very challenging one. I mean, it's in some ways a good problem that we're facing in that there's just been an explosion of new treatments and advances that have come out, but we've got to work to create the infrastructure to keep up with all of those new treatments. So the bispecifics, we are working in our practice to figure out a way to accommodate those in the community. And currently we're kind of piloting this with a couple with some agents where someone like Dr. Swoboda would do the upfront treatment to make sure, which sometimes might require inpatient care and monitoring, and then when the patient is transitioning to more of a maintenance type of phase, transitioning that over to the community. But with these newer agents, I think one is there's a lot that goes into kind of creating the infrastructure and framework to make sure we're able to do that and able to do that safely and well. We don't want to compromise on the care we're delivering by rushing to adapt these treatments before we're ready. But it is a serious concern, certainly. It is something we're trying to actively meet for our patients, and then for folks that just have additional needs in order to make that overcome that barrier, trying to reach out to community resources to fill in some of the gaps. So many organizations may have charity care, and oftentimes there are scenarios where I need to kind of pursue that to see if we can get some assistance that way. Even things like there's certain organizations that might be able to assist with transportation and other things, lodging, and so so we have to sort of use all the tools that are at our disposal to try to meet those needs the best we can.
I completely agree with that. I think whether it's bispecifics, whether it's CAR T therapy, great therapies, but access is a huge issue. We at Tampa General take care of patients regardless of if they have insurance, have good insurance. We really do take all patients in all walks of life, and so we definitely try to access as many programs as possible to help support the patients, whether it's through travel grants through American Cancer Society, funding through Leukemia Lymphoma Society, private donations through the TGH Foundation and other foundation grants that we can then use to support local lodging, approvals for some of these drugs in patients that would otherwise not be able to get them. So I think that's it is a reliance a lot on community organizations and to really step up and try to offer this. I think over time, just like other therapies that have been around, over time, they slowly get more access in the community. And I think with the bispecific programs and newer bispecifics that are easier, CAR T therapy, as we get better CAR Ts that are less toxic, they do transition. But agree, we're missing out on a huge opportunity to do that now, and we definitely spend a lot of time with our financial team trying to bridge that disparity as much as we possibly can, because we know it is apparent and evident, and we're doing everything we can on our end to provide access for patients.
We have another question. Said, I started with a community hematologist and a specialist, and the community doc would not follow the specialist. So now I only see the specialist. Is this okay? Do you recommend a community doc as well?
I think that's okay. I think it depends on I'd say the needs of the patient. So I'm not sure what the particular situation is for this patient, but if they don't necessarily need to, if there aren't a lot of barriers in order to see your academic doctor and you're getting what you need when you need it. There may not be a need for an additional community oncologist for that particular patient, So I have lots of patients that really only need to be seen a couple times a year. And so if you're seeing an academic physician for that issue and your needs are met, it might be one extra doctor that you don't really need to be seeing but it really depends on the circumstance. And then if it's more of your specific needs are not being met, or you're not comfortable with the provider that you're seeing, ask your academic doctor if there is someone in the area that you live that doctor works with. And it's very possible, it's very likely that they probably know have other patients in your region and have worked with other doctors in that particular area. And there might be someone that they are more comfortable with, that might be a little more comfortable dealing with whatever the particular diagnosis might be that you're dealing with. And that'd be a nice strategy too, because more than likely it's someone who has a good line of communication with your academic physician. So I think I'd probably start by asking that your academic doctor if he or she knows someone in the area that they work with.
Yeah, I totally agree with Dr. Kurian. I would say about 20 to 30% of my patients are true primary patients where they don't see a community provider. Most of those patients, live in close or in the Tampa area, and so, they can easily get access to, what they need, at TGH, but ultimately, there's a lot of situations where people are driving 4 hours for specialty services. And, I am constantly, trying to educate the patient that, we really want to do what's best for them, right? And so ultimately in that situation, a lot of times I'm advising them, you probably don't need to be driving this long for routine labs or transfusions. Like, we really should figure out someone that you feel comfortable with closer to your home, that I can work closely with to get some of these services done. But yeah, so again, coming back to, everyone's community to academic relationship is very different. But, I would echo in saying that I think having both in most cases is probably the best, way of doing it. But there is certain situations where, one way or another it might not be feasible, and that's okay as well, as long as you feel very comfortable with the therapy that you're getting and the care plan, and the doctor that's providing the care. I think you're in a good situation.
I think those are great suggestions. We have another question that's similar, but kind of deals with this, this idea of bringing it up. So they say, any suggestions on how to open up this conversation with our primary doctor, specifically when we're the ones suggesting a second opinion?
I don't think any doctor should be offended by that suggestion. I wouldn't let that stop you from having the conversation. Echoing some of what I said a little earlier. I mean, dealing with a cancer diagnosis is about as serious of a situation that someone faces in their life as it gets. And so I think any oncologist should understand that the patient in front of you, needs to feel comfortable and confident that they're on the right track. Even if that means you're getting us another set of eyes to look at it and sort of reiterate the same information, I don't know that I've really come across oncologists that would feel offended by that. I think we all are dealing with we're all dealing with patients that are facing cancer diagnoses and their families, and I think that there's just a level of understanding of what we need to do to meet that patient's needs. And so I would find it surprising if they took any offense to the idea of getting a second opinion. And also it doesn't mean that you're going to break the relationship with that doctor. I may have a patient that goes to get a second opinion, and then will come back to me for continuation of the treatment, but they had that a chance to kind of get a second opinion and ensure that hey, we've kind of thought of all the possibilities here, and we're all on the same page as far as what the next best steps are going to be. So I don't know, Dr. Swoboda, do you have any suggestions on how to have that
Yeah,
conversation? I don't know if
no.
you're.
Yeah. So, I would echo a lot of the similar points. Again, I'm an academic provider, and my patients, there's times where I also recommend, them to get a second opinion, to have a second set of eyes. So, I'll refer patients to other academic centers, to be evaluated for clinical trials. Think about things that in a complex situation. Think about other things. Just have another person that can even say the same things in a different way. Sometimes can be very valuable and very helpful for patients. And so I have one patient, for example, that is in a very gray area when we're talking about a big decision for their care. And so there's no right or wrong answer. And so they are getting a couple of second opinions and figuring out what is the right answer for them. And I'm totally okay with that. I think our role as a physician is to give patients information, and allow them to make the best decision for themselves ultimately. And so in my opinion, if someone is really resistant to having you get a second opinion, then I don't think that doctor necessarily has the values and the best interests of the patient. There might be a specific situation, but ultimately, I would say in most cases, all doctors should be comfortable with that, especially with cancer care, because we should be very used to that.
Yeah, I think that's great advice. And I echo the sentiment that we just got in our last comment says, both doctors are great. We should be our best, most personal advocate. Any doctor who has a problem or acts a certain way about a second opinion or having a specialist on your team, the patient should run and seek another doctor. Personally, it feels selfish. So I think that's a great reminder that I think as patients, sometimes it's easy to feel worried that you're going to hurt someone's feelings or step on toes. And I think it's a great reminder that doctors with your best interest in mind want you to feel comfortable and confident, especially like Dr. Kurian has echoed with the kind of intensity that comes with a cancer diagnosis. It's important that you feel completely comfortable, and your doctors should understand that.
Yeah. And, one thing that we didn't really talk about in this discussion is, having, in addition to having your doctor advocate for you, I think having someone in your family also be there with you during a lot of these complex discussions and also advocating for you, definitely, it has a lot of value because, I give the same, a very similar conversation over and over again to patients. And as many times as I've talking about, a newly diagnosed acute leukemia, and educated, and I feel like I do, as good of a job possible at communicating. It's just an overwhelming amount of information. It's just a lot. And so having someone be there with you that's able to sort of take it in as you're taking it in, advocate for you. I actually let my patients record the conversation if they want that, so they can listen back to it. Because ultimately, at the end of the day, like the best care is going to be when the patient or the patient and the family, understands what they're dealing with and how to deal with it and are ready to, attack it in the best way possible.
I totally agree. More comments on saying thank you and putting the patient first. I think that's a huge thing that can sometimes be lacking in patient care. And so I echo all of the feelings in our community right now. The comments are beautiful. So with that, we already addressed our questions. And I just want to say thank you for all of your guys' incredible insight and your thoughts on this topic. Like I said, this is one that our community was interested in, and I think this will be a great resource. And answered a lot of questions I think a lot of people had. I want to highlight something that can help. It's our HealthTree Care Hub. This platform allows you to electronically connect your health records, and something we talked about, being seen in multiple facilities. This is something that HealthTree Care Hub can help with. It allows you to connect your records from multiple facilities, as many as you're seen in your community, academic, anywhere you've had your blood taken, anything like that. And it puts it all into one profile. So you can see all of your blood work across your treatment experience, all of your different treatment options, things like that. And is a really great way to help you as a patient, like we've talked about, be your best advocate, to be able to see your whole patient experience, see your treatment options. And then once you have that account and you have those labs connected, it allows you to see some maybe treatments that might be potential options for you that you can bring up with your doctors the next time you see them, and helps you to be able to have as educated a conversation as you can with your medical team. This is an electronic connection, so it's pretty easy, but if you were to have any issues with it at all, we have an amazing patient navigation team and a medical navigation team who can help you with it. It only takes a couple minutes, and doing this allows you to not only see your comprehensive overview of your history, but it also lets you participate in research. With your profile already including a lot of your genetic information, participating in surveys is really beneficial to people in the blood cancer community. So I wanted to highlight that program. As we talked, it felt like it was relevant, and if you have any questions, anyone at HealthTree is happy to help you. I wanted to highlight a couple of our upcoming all blood cancer events. So September is Blood Cancer Awareness Month. We've been posting some patient stories across different blood cancers on our social medias over this month. So if you haven't seen those, I would suggest going and watching them. They're all incredible stories. And on September 30th, our HealthTree founder, CEO, Jenny Ahlstrom, is going to be hosting a special webinar for all patients. This is going to be a really exciting event. It's all centered around innovation happening in the field of hematology. So we're bringing in top specialists from each of the major areas of hematology: multiple myeloma, leukemia, lymphoma, and MPNs. And they're going to highlight the exciting research happening in their field. So this is a really exciting event that I think everyone should join if you're available, or at least register so we can send you the recording afterwards. And then on October 1st, we have a financial advisor who's on our HealthTree staff. Her name is Diana, and she is wonderful. And she's going to be coming on to talk about upcoming changes to Medicare. So 2 exciting events in the rest of this month that will both be really informational. So I hope to see people at those events. Again, I wanted to thank our sponsors who make events like this possible. Those are Pfizer, Regeneron, Johnson & Johnson, GSK, Karyopharm, Bristol Myers Squibb, AbbVie, Sanofi, Adaptive, and Genentech. And then finally, I just wanted to say thank you to everyone on the call today for helping us to build our communities, our patient communities. My email is on this slide, and if you've attended events for your specific diseases before, I'm sure you have the access to your disease education manager's emails as well, or you can email me and we're happy to get you to who you need. If you have questions, if you have suggestions for topics you'd like to see us cover, that's what we love to cover the most. So please send those. And I appreciate you all. I hope you all have a great rest of your day, and I hope to see all of you at another HealthTree webinar soon.